Hello everyone and welcome back to Clinical Cousins YouTube channel. Today we're going to go over how to determine if your patient has a left bundle branch block or an LBBB. So the first thing we need to know about left bundle branch blocks is that they are usually very strange looking on our EKG. So if you get a weird sort of awkward looking EKG, then your first thought should be, well, it might be a left bundle branch block. And an important little side note to remember if you've been reading EKGs for a little bit is that you cannot diagnose left ventricular hypertrophy in LBBB or left bundle branch block. And this is because this slow cell-to-cell depolarization, we know that this sort of awkward vector here is going to distort the amplitudes of our QRS complexes, which means that it'll be impossible to use that slur NEC 1 AVL feet. It'll be impossible to fit these into that criteria because they're not going to be normal complexes. They're not going to represent how large that left ventricle actually is, so just keep that in mind. So first we need to remember that the left bundle branch is divided into two fascicles. So there's the anterior superior fascicle and there's also the posterior inferior fascicle. So these fascicles innervate, which is a fancy word for electrically activate, the anterior and superior and also the posterior and inferior aspects of our left ventricle respectively. So think of the left bundle branch as sort of the stem for these two fascicles. So when the stem is cut, neither of our fascicles will work and the left ventricle will not be able to be activated quickly or as quick as it is used to being activated. So imagine that our left ventricle is like a big city and that the left bundle branch is like us sending an email to the entire city all at once. So we know this is very fast, it's very organized, but if we say that our left bundle branch up here in the septum is blocked, like if our internet was down for example, then we would have to send one message to be handed from cell to cell until it reached every single cell in our left ventricle cell city. So this is what a left bundle branch block does. It makes our left ventricle rely on this slow cell-to-cell depolarization. So this slow cell-to-cell depolarization generates a slow depolarization vector that is headed leftward, right? This is, or not right, left. So we have a leftward depolarization vector. It's headed from the interventricular septum leftward because this is where it would normally occur if this left bundle branch was working. So we already know that our lead V1 is looking more at the right side of our heart. So it should be no surprise to us that this leftward depolarization that is heading away from V1 will look more negative, right? Pretty girl headed away from our lead, so that's going to appear negative. And we also remember that leads 1 and V6 are more on the left side of the heart, right? They're more lateral, so it will be no surprise to us that this leftward depolarization, this pretty girl vector that is heading towards leads 1 and V6 will appear more positive. So we talked about left bundle branch block, but what are some actual causes that are probably happening in our patient? Well, we know that prolonged and uncontrolled hypertension, coronary artery disease, sometimes called atherosclerotic disease in the coronary vessels. It can sometimes be seen in, we know that alcoholics can get dilated cardiomyopathy, so this can be seen in alcoholics sometimes as well. And it can also just be benign or idiopathic, so the patient could have always had this. That's why it's really important to get serial EKGs and then compare them. So that brings us to the golden rule of EKGs is always read them in context of your patient's history and presentation. So never read them just in a vacuum. So we need to remember this as we talk about our EKG changes today because this is the basis, and if we have a good understanding of this, then all of this will become very easy. So the phrase that we have to remember is LBBB in 116, or long bulbs become bigger in 116, or long bulbs become bigger in V1, 1, and V6. So let's break that down. Long bulbs become bigger. This means that our QRS complexes are going to become equal or longer to than the 0.12 seconds. So we know that the normal QRS duration is 0.06 to 0.11. So when we have something that's equal to or longer than 0.12, then we know that this represents a block. So we have a block. How do we know that it's left bundle branch block? Well, we'll see these bulbous we're looking QRS complexes, but where do we see it? Well, we have to look at V1, 1, and V6. So in lead V1, we will have these small R waves with sort of deep and wide S waves, which sort of look like complexes in VTAC if we were to string them all together. So the important thing to remember here is that when looking at V1, because the depolarization vector is headed away from V1, then these will appear mostly negative. It'll have more negative than positive. So we know that we'll have a long negative looking bulbous complex in V1. So next we see that we're going to have a long bulbous looking, or sometimes called monomorphic, QRS complex in leads 1 and V6 as well. So this is because we have to remember we have a depolarization vector, we have a pretty girl that is headed towards R1 and V6, and it's walking towards them for a long time. So we're going to have a mostly long and positive QRS complex in leads 1 and V6. So let's do a little recap. So the left bundle branch breaks into two fascicles that innervate the left ventricle. So when the left bundle branch is blocked for some reason, like hypertension or coronary artery disease, then our left ventricle must be activated by the slow cell-to-cell depolarization vector that is headed leftward. So how do we see left bundle branch block on an EKG? Well, we have to remember LBBB in 116, right? Left bundle branch block in 116, or long bulbs become bigger in V1, 1, and V6, meaning that we have long, bulbous, or wide QRS complexes that will be greater than or equal to 0.12 seconds. And where will we see these changes? Where will we see these QRS complexes? Well, we're going to see these changes in lead V1 as a small R wave. See, it's very, very small here. A small R wave with a deep S complex that is mostly negative. So it's mostly negative in V1. We're also going to see these changes in the mostly positive QRS complexes in leads 1 and V6. Remember, these are sort of located in similar places but different planes, so they're going to have similar EKG changes. That's just a good rule to remember. So when we put it all together, we have long bulbs become bigger in leads V1, 1, and V6. So as always, thank you for taking the time to learn with us today, and remember to like and subscribe for more content. Thank you so much.